may have a role, but as I said before, this is not something that we study directly in this paper.
Well, do you think this particular schedule is appropriate for other GI groups around the country?
No, not necessarily at all. I think that, what I would encourage, what we did was we sat down at our practice meeting and we looked at the workloads of the individual physicians. We looked at the patient intensity mix. We looked at our ancillary services. We looked at the economic parameters of the practice, such as the payer mix and our overhead and so forth and so on. And we tried to plug it all into an equation and come up with what worked for us. I think the only comment that I would make would be that gastroenterology practices, whether group practices like ours, university practices such as we have at Mount Sinai, VA practices, or wherever, should be sensitive when they're devising scheduling to the potential impact on quality of production pressure.
Well, you mentioned at the beginning that one of the things you wanted to study were the sessile serrated polyps. So what did your results reveal about that?
Great. So we have an expert GI pathologist who we use and who read all the slides. And we found in our group that the SSP detection rate was about 8% during routine colonoscopy. So if you do the math, that means about 1 in 12 cases had an SSP. And if you look at adenomas versus SSPs, the ratio was about 5 to 1. This is this practice is one practice, and how generalizable those results are remains to be seen. It's unclear to me whether, they would be the same year to year in our practice or, in other practices. But nonetheless, this may be a starting point for trying to develop some benchmark data regarding SSP detection rate. The other thing that was sort of interesting to us, Bruce, was that the SSP detection rate of 8% is similar to what's been seen in studies using chromoendoscopy and magnification endoscopy and other sort of research type techniques, suggesting that with excellent bowel preps and attentiveness to the issue of SSPs, it may be possible to approximate those higher rates without utilizing different technology.
Right. Well, to sum it up, what would you say are the take-home messages of your study?
Well, I would say really twofold. I think the first is that under appropriate practice conditions, which still need to be defined, I think that the premalignant polyp rate, detection rate during colonoscopy can be stable over the course of the workday. The second thing is that variables that may be relevant to predicting that would include the types of bowel preparations you use, how you schedule your patients, and potentially other things, patient-related factors that were not really analyzed in this study. The third thing I would say is that it is potentially valuable to develop a sessile serrated polyp detection rate as an independent variable, an independent measure. I want to record these conclusions again because I got the first one slightly wrong and I want to get the second one.
Okay, let me pause this. I think it...
So Jamie, that's great. Maybe you could sum up and tell us what you think the take-home messages are from this study.
Thank you. I would say, first of all, we found that under appropriate practice conditions, the premalignant polyp detection rate during the workday during routine colonoscopy can be stable. We hypothesized that bowel preparation quality may play a role in that. We also hypothesized that scheduling issues and issues related to production pressure may play a role in that, but those remain to be tested in prospective studies. The second comment I would make from this research is that the SSP detection rate is something that can be readily determined in a routine practice, and it may well prove to be an independent and valuable measure of colonoscopy quality.
Well, great. Jamie, thanks so much for the discussion. It's been an interesting talk.
Thank you, Bruce. Thanks for being here.
My pleasure.